this question. The surgical and the anatomical. Anatomically, as you remember, it is part of the small intestine. By the way, that is the first part of the small intestine. And anatomically, we will describe what is the position, what is the relation, and what the function, shortly, briefly. But what is the surgical point of the view of this question? You know, surgeons have a little bit another opinion about the duodenum. They think that this is the separate, unique part of the digestive tract, which is located between the stomach and small intestine. Surgeons call the small intestine only last two portions. That is the jejunum and the ileum, otherwise the intraperitoneal portions of the intestine. And I can explain you why. Because what is most important for the surgeons? It is primary, where is located the structure, and how we can make the access to this structure. Now, from that point of the view, these two parts of the intestine, I mean the duodenum and the jejunum ileum, completely differ from each other. Predominantly, duodenum located in retroperitoneal space. Predominantly, duodenum located in the level of the upper compartment of the peritoneal cavity. For the jejunum and the ileum, absolutely another situation. They located intraperitoneally inside of the peritoneal cavity, and they located, of course, below transverse colon and the mesocolon. Primary, mainly, listen me. Not try to write everything which I tell you. Let's say this is the surgical point of the view. What is the duodenum? Duodenum, it is part of gastrointestinal tract. You know, very interesting, but functionally, physiologically, duodenum also is different from the small intestine. As you remember, the main function of the small intestine, generally, it is absorptional function. It is the huge place for the absorption. Yeah, and of course, this is the main part of our digestive system from the point of the view of the absorptional processes. In the duodenum, we don't have primary any absorption, or it is not so developed. Here we have production. We have the production, we have the juice of the pancreas, which is entering inside of the duodenum. We have the bile, which is entered the duodenum. That's it. Functionally also, you can see that these two parts of the intestine is completely different from each other. Let's say, remember, please, these two different, we can say, point of the views of this structure. And let's start to discuss it. Again, I ask you, listen me. Finally, guys, come to conclusion that I mean the teachers, we need your active involvement in the process. Not the passive writing involvement, but active involvement. Now, let's start from the place of its location. You know, here there are dualistical problems because partly, very shortly, it is located inside of the peritoneal cavity. That is mainly superior horizontal part, which divides into two parts. As you remember, the most near 2 centimeters, approximately this portion, to the stomach, we call intraperitoneal. Rentgenologically, by the X-ray, we call it the bulb of the duodenum. You know why the bulb? If you make the X-ray contrast pictures using some dyes, yeah, coloring substances, you see immediately after the pylorus, let's say you give, for example, barium, your patient is swallow the barium, and you make the pictures of the abdomen. And what do you see? During the time the barium from the esophagus reaches the stomach, then it is passed from the stomach. You see the narrow pyloric sphincter, and immediately after the narrow pyloric sphincter, you see enlargement in the form of the bulb, like the onion bulb. That is the first 2 centimeters of the duodenum, which is intraperitoneal. So remember, please, bulb of the peritoneum, duodenum, it is related with the intraperitoneal portion of it, And next, approximately 3 centimeters, because whole length of superior horizontal part near the 5 centimeters. Next 3 centimeters, it is mesoperitoneal. As you remember, intra and mesoperitoneal organs located inside of the peritoneal cavity. All another parts, I mean the longest descending part, inferior horizontal part, and ascending part, it is a retroperitoneal structures. Conclusion, question number 1, how you answer in your exams or your controls. Place of location of duodenum. Duodenum located in 2 different compartments of abdomen. Only superior horizontal part has peritoneal location, it's located in peritoneal cavity. All another parts have retroperitoneal location. They located in retroperitoneal cavity. That's all. That's a question number 1 we discussed together. Where is located our duodenum? Question number 2 is related with first one. How it's covered by the duodenum, by the peritoneum. So, as I said before, it's superior horizontal part, dualistically covered. Predominantly, it is the intraperitoneal, and a little bit less, it is the mesoperitoneal. Yeah, let's say these 2 portions. I lose the key of this one. Okay. These 2 portions, it is covered and located inside of the peritoneal cavity. It's an intraperitoneal portion and the mesoperitoneal. All another parts of the duodenum, as I said before, it is extraperitoneal or retroperitoneal, means they covered by the peritoneum only from in front. Let's say this is question number 2. We discuss its relation by peritoneum. Question number 3. Holotopy. How it is projected into the walls of the abdomen? Answer is very simple. Now look to me. Except superior horizontal part and approximately upper 2/3 of the descending part, lower 1/3 and all another parts will be projected in mesogastral region. That's like above mentioned parts, once again, superior horizontal and descending 2/3 of upper 2/3 of the descending portion will be in proper epigastrium. All another compartments will be in the mesogastrium. So we answer into the 3rd question, mean how we can project it the duodenum. Remember once again, superior horizontal part, descending 2/3 located in proper epigastrium above the bicostal line. All another portions located in the mesogastral region. Super. After the holotopy, we start to speak about skeletotopy. To answer into the skeletotopy, you should imagine for you this horseshoe-shaped structure, which is started in the level of L1, approximately that is its original location. What does it mean, its start? It means the pyloric sphincter. So pyloric sphincter belongs to the stomach, and immediately its continuation, it is the superior horizontal part of the duodenum. That is the level of L1. And it is finished, let's say this aperture, which you see, this is generally we can say the pyloric aperture, yeah? Aperture which is divided our stomach from the duodenum. Let's say this is the first aperture of the duodenum, or otherwise we can call it entrance of the duodenum. But you can see an exit of the duodenum, and it's located below the first one. It is approximately level of L2. And we call it the duodenum jejunal junction. Let's say duodenum started with the junction with the stomach, pyloric aperture region, and it is finished by the junction with the jejunum. Level of L1, level of the L2. But between them, there are the huge part. Let's say, remember this skeletotomy, please. The superior horizontal one, horizontal line in the level of L1. By the way, if you will look to the real location of it, superior horizontal line part predominantly and mainly located into right side from the middle line of the body. Let's say then you provided the midline of the body. Approximately your pylorus will be in the level of the midline. Last time in my practical class, I spoke about scalability of the stomach, and we mentioned that the pylorus located in the level of the 8th cartilage, approximately by midline of body, or a little bit right to it, into 1 centimeter. Let's say then we speak about superior horizontal part of the duodenum. I'm very sorry. We mentioned that it is L1 level, immediately right side from the midline of the body. I think it's not hard to understand. Yeah. Then we come to the descending part. And by the way, between descending part and superior horizontal will be the first flexura of the duodenum, which we call flexura duodenalis superior. Superior duodenal flexure. Again, the level of the L1. Now your descending part of the duodenum started from level of L1 and it is finished immediately in the level of L3. By the way, how it will be located? It is located immediately in the level of the tips of transverse processes, right tips of the vertebra. Let's say this is, as you remember, also place of location of our inferior caval vein. Let's say your descending part of duodenum will be immediately in front of your inferior caval vein. Let's say, once again, look to me. If you want to understand how it is projected in anterior wall, from midline you will come into 5 centimeters into the right side, and from that place you will go to down approximately into 7-8 centimeters. That is the level of the 8th rib, approximately. Yeah. Let's say from the level of 8th rib you find in the midline. You come into the 5 centimeters into the right side, and then into 8 centimeters you descend it to the 8, 9. By the way, you can see that descending part approximately twice longer than superior horizontal portion. Then you will see next flexura, which we call flexura duodenalis inferior, which will be in the level of the L3. And from flexura duodenalis inferior, we will have the next, third portion, which we call inferior horizontal part. Inferior horizontal part approximately equal to the superior one, a little bit longer. And we will come again to the place where we start our destination. I mean the level of the midline. So from level of the midline, superior horizontal part is starting, inferior horizontal approximately come to the level of midline or little bit, 1 centimeter left to it. After by the way, again I say you 5-6 centimeters will be the length of it, yeah? And that is the level of L3. Let's say once again, L1 to L3, and level of the L3. Now you come to the last portion, which we call the standing. And by the way, between inferior horizontal and the standing part, we don't have flexura, because it is a little bit curvily goes from down to upwards. And finally, this your inferior horizontal, ascending part reach the level of L2. That's it, from the level of L3, where is located the inferior horizontal part. It is come to the level of L2. And what is happened in this level of L2? Now look everybody to me. Duodenum from retroperitoneal space perforated parietal layer of the peritoneum, which is covered the posterior wall, and it is become to the peritoneal cavity. And this peritoneal portion of it we will call the jejunum. And the part which is located in the level of this perforation we will call flexura duodenojejunales. Flexura duodenojejunales located in the level of L2. A little after we will describe together the ligaments of the duodenum. And remember, please, in the place of this perforation, we have the suspensor ligament. Otherwise, we call it trace ligament, which is the fixation of the duodenum in its place. Let's say, remember please this skeleton P again, the level of L1, first flexura level of L1, the level of L1 to L3, descending portion, second flexura level of L3, then level of the L3 inferior horizontal part, then from L3 we come to the L2 level and formation of the third flexura in the level of L2. We finished to speak about projection. We finished, let's say guys, immediately in the same kind you will answer in your any examination questions. Now next point, what is the relation of the duodenum with the neighboring located structures? We call it syntopy. We cannot describe syntopy for all parts together. That's why I write this. This is important. Syntopy of the duodenum. Syntopy of duodenum. And write please that the syntopy of the duodenum describes separately for different parts of it. I will seek it to show for you guys this relation. That's all right, please. Portion number 1. Superior horizontal part. Superior horizontal part. Right, please. From upwards, it is faced to the liver, visceral surface of the liver. Primary, it is lobus quadratus, yeah? And also to the inferior surface of the gallbladder. Inferior surface of the gallbladder. From downwards, it is faced to the head of the pancreas. Firstly right, then I will show it for you. From anteriorly, it is faced to the fundus of the gallbladder. Fundus of the gallbladder. And anterior abdominal wall. From posteriorly, it is a retroduodenal portion of the common bile duct. And also it is the portal vein. And also it is the portal vein. Number 2. Before start to write the second part, 1 minute attention to the picture. Liver is removed here. Let's find the picture with the liver. Let's say this is the superior horizontal part. As you can see, from upwards we will have the liver, we will have the gallbladder. From below, you can see here there are the head of the pancreas. It is greatly visible for you. Behind of it, you can see the portal vein, yeah, which is formed immediately behind of the head of the pancreas. Then it is ascending to upwards to be entered inside of the hepatoduodenal ligament, yeah? But primary in this level, it will be behind of superior horizontal. Second bile ducts you cannot see, but you remember there are 4 portions of the common bile duct, and immediately second portion we call retroduodenum, because it's located behind of the superior horizontal part of the duodenum. By the way, how we call another 3 portions of the common bile duct? You please. This is what I completely described you in my previous lesson. That's it. Friends, 100 times I repeat for you, come in the lecture with the knowledge. Otherwise you will be here as just some strangers who don't understand anything. 2 lessons before I gave you to study the liver and the bile ducts. How is it possible to come today in my lesson without knowledge? I don't have the time to waste and ask you, but this is the supraduodenal part. Then our part, which is behind the duodenum, retroduodenal part. Then pancreatic part, which is located in the head of the pancreas. And finally, it is the intramural part, which is, what does it mean, intramural? Now, can you translate this term from the Latin into the English? What does it mean, intramural? What is the mural? Just translation. I don't ask you even any knowledge from my subject. or you will not change your behavior. You will be confused all your life. All your life you will be confused. All your life. Because everything in medicine will be new for you. Intramural, it means inside of wall. Murus in Greek, it is the wall. As intramural, it means inside of the wall. What does it mean inside of the wall? It means it is perforating the duodenal wall and opening the tip of papilla duodeni major. That's why once again, then we speak about superior horizontal part of the duodenum. Above it, we have the liver, we have gallbladder. By the way, it is the fundus of the gallbladder. Below it, we have the head of the pancreas. In front of it, we have the partly again fundus because it has hook-shaped form. And we have anterior wall. Behind of it, we have the inferior we have the portal V, and we have the second portion of the common bile duct, which is called retroduodenal portion. Now right, please, second portion, it is descending part of the duodenum. Now right, please, anteriorly to it, again we have the liver, we have the transverse colon and its mesocolon. Transverse colon and its mesocolon. Open the brackets and write, please, transverse colon and mesocolon, mainly mesocolon, allocated in the border between middle and lower thirds of the descending duodenum, approximately level of papilla duodeni major. One minute attention into the picture. Look here, please. This is right knee of transverse colon. Transverse colon is cut in here. But if I will make imaginary continuation of this transverse colon from right to left side, you will see approximately the place of attachment of the mesentery. Say, root of mesentery of transverse colon will be here. For green part, as you can see, this is the border between the middle and between the lower third. And immediately in this border, in the medial wall, we have the fateri papilla, or papilla duodeni major, the place of the opening of the two ducts. It is the common bile duct, and this is made pancreatic duct. They fuse to each other and open in this level. Let's once again look in the picture. What is in front of your descending part? Here, guys, we will have mainly, again, liver, because it will have also the curved-shaped form, yeah, and will cover it portion. It will be transverse colon and transverse mesocolon, which will be again in front of it. Now, right, please, behind of it, the main structure, it is the inferior caval vein. Inferior caval vein. And the most medial margin of the right kidney. Minute attention into the picture. Inferior caval vein is not so good visible because it is located behind, but you can see where is located the kidney. Let's say this is the level of the kidney pelvis. Let's say immediately in the level of the kidney pelvis, in front of the right kidney, we will have the descending part of the duodenum. Remember it, please. Friends, you can say why the teacher so meticulously speak about this symptom. You will be zero during the surgery if you will not recognize what is related to the operated organ. Only this can give for you success for the surgery. Let's say once again, if I need to reach the descending duodenum, what I must do? First, I must lift the liver because it will cover it from in front. Second, I must understand that in front of the descending duodenum, I will have parietal layer of the peritoneum because it is the retroperitoneal structure. It is located behind of it. Then I must understand that behind of it, I will have inferior caval vein, very attentive during the resectional manipulations. This is the biggest vein of the human body. And a little bit right to it, we will have the pelvis of the right kidney. Right, please, medially to it. Again, we have head of the pancreas. we have the head of the pancreas. Inferiorly to it, we have the loops of the small intestine, which is located in front of the parietal peritoneum, which is covered descending path. Laterally to it, we have colon ascendens, ascending colon, and also right knee of the transverse, but it will be much more in the right side, mainly ascending portion. Here you can say why it's not good visible, guys, because intestine is retracted to the sides. In reality, it will be here approximately, in this level. Let's say it is distended a little bit, retracted to the sides, yeah, to show for you the structural units. Now, right, please, inferior horizontal part. Inferior horizontal part. From upwards, we have again head of the pancreas, and we have superior mesenteric vessels. Superior mesenteric vessels, in the brackets right, please, originating from the level of L1, they descended to down, and located in front of the inferior horizontal part. In front of inferior horizontal part. Above it, as I say, we have head of the pancreas. Below it, we have the loops of the small intestine. Behind of it, we have aorta abdominalis. And we have inferior mesenteric vessels. Inferior mesenteric vessels. Ascending portion. Anteriorly, transverse colon and mesocolon. Loops of the small intestine. Root of the mesentery, radix mesenterice of the small intestine. Again, superior mesenteric vessels. Posteriorly, again, abdominal aorta. Into the left side, it is turned into the jejunum. Into left side, it is turned into the left jejunum. Is it understandable for you? That's we understand completely what is related with the different parts of our duodenum. 1 minute attention now to me. Which surgical performances generally we can make into the duodenum? Mainly, friends, this is resectional surgeries. And by the way, in majority of the cases, it is connected with two problems. Problem number one, it is the duodenal ulcers with complications. As you remember, I told you before that there are 5 complications which is need to operate the ulcer problems. First one, it is perforation. Second one, it is penetration. Dear Xyron, do you remember what does it mean, penetration of the ulcer?
When there's when the ulcer has penetration inside.
Inside of what?
The intestine.
You mean then it is perforated? In that case, what the difference between perforation and penetration? There's a perforation if it is completely grow in all wall of the organ, and the organ is perforated, content of organ can come to outside. That is perforation, but I ask you what is penetration? Because perforation and penetration, that is not the same. No option? No option. Maybe you, dear friend, on 3 years in medical university, can you tell me what does it mean that, and what is funny for you, dear? Why you have so paradoxal reaction? Any times that I ask the question, you start to smile and laugh. Please. Who can tell me what is the penetration? Oh, awful. Remember, please, penetration, it is the growing of the ulcer from one organ to another organ. Then the ulcer is grown from one organ to another organ. We call it penetration. 1 minute attention to me. Again, I can ask the question, what the difference between perforation and penetration? In case of perforation, we have formation of fistula with the cavity. In case of penetration, we have the fistula between two organs. For example, from the duodenum, ulcer is penetrated into the pancreas. This is penetration, means the growing of ulcer from one organ to another organ. Let's say once again, perforation, penetration. Problem number three we call malignization. Can you recognize what does it mean? Malignization. No. Malignant structures. Which structures we call malignant? Huh? Cancers. Of course. Then 1 minute attention, ulcer become to cancer. And you study the histology, you study the pathanatomy, yeah, I think you understand why this happened. How it can be happen that ulcer become, simply guys, this is actively regenerated structures. You understand that epithelium of your intestine very quickly and fastly regenerated, yeah? But imagine that there are chronic irritation here, ulcer. These actively divided cells will be irritated as a result of it, you know, yeah, dysplasia, metaplasia, anaplasia. The more active is cell, the more is possibility during the irritation to achieve the malignancy of the problem, formation of the cancer. Because the rate of division is very high, and during these divisions we can have mistakes, which is called mutation. Mistakes of the division, which is called mutations, it is the etiology of formation of the cancer. Let's say, remember once again, perforation, penetration, malignization. Number 4, it is the bleedings. Because in the time of the growing of the ulcer, big vessels can be damaged, and we can have profuse up to the mortal bleeding. Little after I will speak about arterial supply. And last one, 5th one. Please, logically, guys, let's have conversation. Let's make the lesson more interesting for us. Now, ulcer disease in 21st century, treated, of course, therapeutically. We have the special medicines. By the way, you study pharmacology. What is the main achievement which you will reach during the treatment of ulcer disease? What is the main achievement? Which goal you will reach? No. Of course no. Friends, you are in 19th century or in the first part of the 20th century, you know? Because starting from second part up to now, we know that the main cause of the problem is Helicobacter. So I must to reach the eradication of the Helicobacter first of all. That's why I need the antibiotics. And you are right. Together with it, I will use the medicines which is increase the reparation, which is the decrease the breakdown, the acid environment, which is make the stabilization. But the main goal which I must reach, it is of course it is the antibiotic therapy. It is the eradication of the Helicobacter pylori. But again, I tell you guys, that's like, let's understand, that's like, in 21st century, ulcer disease treated therapeutically. And I mentioned for you only the 5 complications. By the way, I say name of the 4. What will be the fifth complication? Huh?
Sepsis.
Why will we have sepsis? Will be in case of perforation. We say about it, yeah? Why will be sepsis if the perforated ulcer will have?
Because of blood stream connected into the bloodstream and
Friend, which blood? What about your spleen? If the duodenum will be perforated, its content will come to the peritoneal cavity. What will be happen? Peritonitis, of course. And peritonitis and sepsis, it's equal to each other because immediately these toxins will be absorbed inside of the vascular pathway. That is the problem. That's a 100%, Lisa, 100% peritonitis. It is mortal without emergency treatment. Your immunity system, your forces and powers is not absolutely enough to resolve this problem. Only emergency surgical treatment, cleaning, washing, drainage, antibiotic therapy can resolve this problem. Otherwise, the person 100% will be dead. And so once again, I ask my question, what is the fifth complication of the ulcer disease which can need the surgical treatment? I say perforation, penetration, malignization, and bleeding. What is the last one? Switch your brain. What will be happen with tubular organ? What? Who say? Brilliant, of course. Obstruction. Why obstruction? Because I will have aggressive regeneration here, yes or no? Finally, this connective tissue scar can be formed so much that it can, don't forget guys, that this is the most narrow portion, especially the level of your descending inferior portions, because first 2 centimeters of superior horizontal, it is wide. But then it is become to the narrow. Lumen of it near 2.5 centimeters. That's why any scarification of the ulcer here can be the cause of formation of the obstruction. That's why remember, please, first case and first cause of the surgeries, it is the complication of duodenal ulcers. Don't forget that the ulcers located not only in the stomach, in case of ulcer disease, but on the duodenum. By the way, duodenal ulcers, it is mainly the youth problems. Stomach ulcers, usually it is the adult's problem, but it can be happening in different ages. What is the second problem, in your opinion, which is need to make duodenal resections? So I say you, main surgery which we provide here, it is resectional surgery. And I give you previously 5 causes that we need this resection in case of the ulcer disease. What is the second cause of the surgery here, mainly? By the way, to tell the truth, there are 3 causes. And there are 2 more. Of course, second one, it is the malignancies. Then there are primary tumors. Yeah, of the duodenum, we must make here the resection. What is the third problem? You sleep in my previous lesson, then I draw for you the diagram of arterial supply and of course pancreatical problems. You know what the problem? Pancreatical resections in majority of the cases we should do together with duodenum. We make so-called duodenopancreatic resection. Why? Because supplemental vessels is saved. I draw for you superior pancreatoduodenal and inferior, and then you will ligate it one from these vessels. You will destroy supplement in both organs. It will be impossible to keep one from them. Otherwise, nowadays, we make the microsurgical reconstructive surgeries. It is very hard to keep one from these 2 organs and to remove another. Because then you ligate the source of the supplement of one from this pair. In the same time, you destroy the supplement of another. That's like if there are pancreatitis, especially it is the necrotizated forms, yeah? If the pancreas, head of the pancreas, it is destroyed and should be removed. Usually we do pancreatoduodenal resection. We resect it and remove both these structures together. Let's say this is the 3 causes of the open surgeries which we do here. Once again, ulcer disease complications, malignancies, tumors, and number 3, pancreatoduodenal resection. We can make here endoscopical manipulations, yeah? Do you know which one we do it here usually? Whole angiopancreatography. Whole angiopancreatography. Do you know what is it? You don't know. Very bad that you don't know, guys. To answering this question, what is it? What is it? I must remind you the structural units. This is 2 ducts, which 100 times today I mentioned. One, it is the main duct of the pancreas, which is collecting the pancreatic juice. And second one, it is the main bile duct. As you can see, they join to each other. And in the level of the middle lower thirds, they enter in the tip of the papilla duodenum. They forms ampulla hepatopancreatica. That's why, what does it mean? Cholangiopancreatography. It means endoscopically, usually from fibrogastroduodenoscopy, yeah? You insert the endoscope inside of it. You insert it inside of papilla duodenum, tip of your injector, and you inject it the special contrast inside of the bile and pancreatic ducts, and you make the X-ray to detect it, the abstractional place. Because unfortunately, sometimes the gallstones can be moved inside of the ducts and can give the abstraction. That is very critically dangerous. Now imagine that the stone will come to the tip of the papilla duodenum and will close it. Which possible complications it can give? Bile, look to me, from the common bile duct can be regurgitated inside of the pancreatic duct. That is awful. This is the main cause of formation of acute pancreatitis. Why? Because bile activated pancreatic ferments. Yeah? Trypsin, lipasa, amylase, yeah? They activated by the bile. And what will be happen? These ferments will be activated inside of the pancreas. And they will make autolysis. They will eat the tissue of the pancreas. That's why we need to understand where is located the stone, and endoscopically, if it is necessary, through the papilla duodenum major, we can make the extraction of this stone to outside. That's why up to now I explained for you what is the surgical importance. That's why open surgeries we can perform here. We can perform here endoscopical surgical performances. And you must know that duodenum has great surgical importance. Very quickly about the vascularization and innervation. In my previous class I told you, look please here, unique picture you can see. You can see that there are 2 vessels and both of them equally supply the head of pancreas together with the duodenum. From these 2 vessels, as you can see, superior one, arteria pancreata duodenalis superior, it is the branch of the gastroduodenal artery. As you remember in my previous class, I drew for you that gastroduodenal artery originated from arteria hepatica communis. Hepatica communis gives the gastroduodenal branch and change its name. It becomes to hepatica propria. Gastroduodenalis gives 2 branches, one to the stomach, arteria gastroepiploica dextra, which is passed along the greater curvature of the stomach. And second one, it is arteria pancreata duodenalis superior. Look up to which place it's born. Again, papilla duodenum minor. Up to the level, you can draw in this level horizontal line. Head and duodenum above this horizontal line will be supplied by arteria pancreata duodenalis superior. Duodenum together with head of the pancreas below this line will be supplied by another artery, which is called pancreata duodenalis inferior. Let's say superior and inferior. What is the origin of it? If previous artery originated from truncus coeliacus, as you remember, this is first single branch of abdominal aorta, level of T11, T12. Inferior part supplied by arteria pancreata duodenalis inferior, which is originating from superior mesenteric artery. This is second single. Finally, there are a third one, yeah? Inferior mesenteric. That's a superior mesenteric artery in the level of L1 will give the inferior pancreata duodenal artery, which will supply head of the pancreas together with the duodenum below the level of the papilla duodeni major. What is the problem here, guys? Unfortunately, in the tip of these two lines, no any enough anastomose formations. This is the big problem. They say, if you will ligate it, for example, one from these vessels, second will not compensatory supply all another regions which is belong to these two arteries. Anastomosis is the bad development. That is the cause why we make pancreato-duodenal resections. Again, I tell you, because supplyment of these two structures is common. Is it understandable? So, once again, remember, please, the level of papilla duodeni major and two arteries above this level, pancreata duodenalis superior from gastra duodenalis, which is belong to the celiac tract, and below it, pancreata duodenalis inferior, which is belong to the superior mesenteric artery. Is it understandable? Friends, again I tell you, I especially say you don't write anything, to listen, to have the conversation together. By the way, forever, our lectures will be provided in such a form. I know why majority of the teachers make the writing lectures to waste the time to read the material because they don't know your own material. That is awful. We don't need to waste the time. We need to have the conversation. Now let's speak about venous drainage. What is important, guys? And superior pancreata duodenal and inferior pancreata duodenal veins, both is drained into the superior mesenteric vein. That's why from both venous blood goes into the portal venous system. How it's happened, you remember, 100 times I told you, but we have it here in the picture. You can see this system, which is forms immediately behind of head of pancreas, behind of superior horizontal part. What do you see here? Three primary blue lines, I will say violet lines, because by blue color here you can see portal venous system. By violet color you can see, by blue color caval venous system. By violet color you can see portal venous system. And attract your attention into these two structures now. Splenic vein, superior mesenteric vein, they join to each other behind of the pancreas, and approximately 2-3 centimeters right to this junction, please, they join to the inferior mesenteric vein also. And by this find, let's say some literature say that 3 veins join to each other to form portal. It is splenic, superior mesenteric. Another literature say another thing. Say superior mesenteric firstly drain into the splenic one, then splenic connected with inferior mesenteric vein and forms the portal system. So doesn't matter how you will call it. Generally remember, please, that these 3 veins should be joined to each other, and immediately behind of the head of the pancreas we will have its formation. What is happened after with portal vein? I told you before. It is passed behind of the superior horizontal part of the duodenum. It is entered inside of the hepatoduodenal ligament, and together with the choledoch and together with proper hepatic artery, it goes into the hilum, into the porta hepatis, where it is divided into 2 terminal branches, right and left. And branchings of the portal vein will form the segmental division of the liver into 8 segments, 4 in the left, 4 in the right lobe. Is it understandable for you? Very well. About the lymphatic drainage of the duodenum. Lymphatic drainage of duodenum and head of the pancreas also is common. From these both mentioned structures, lymph is drained into the retroperitoneal space, into the lymphatic nodes, which is located along the inferior caval vein, immediately right side to the midline of the human body. From here, they goes to upwards into the posterior mediastinal lymphatics, and finally, by ductus thoracicus, drain inside of the system of the superior caval vein. Innervation also not hard, guys. Vagus provided parasympathetical branches. Primary, it is the right branches of the vagus. And plexus celiacus provided postganglionar. It is inferior, mainly inferior thoracic branches, which is become to this region and make the sympathetical innervation of the mentioned structures again together, and duodenum and the pancreas. That's all. I think it is not so critically hard. Let's continue. Write, please, now the name of the next structure, and again attract attention to me. Again, attract attention to me. By the way, guys, the length of your duodenum, it is from 28 up to 35 centimeters, approximately. Yeah? Now, pancreas. I think you know a lot about it. You studied during your histology, during your anatomy, during your physiology, and first of all, that is the unique structure. By the way, from some point of the view, it is resemble to liver. Because liver also has dualistical function, and exocrine and endocrine, yeah? You remember the different form of the somatostatin produced inside of the liver, yeah? We have production inside of the liver factors, which is activating the growing processes of the blood elements, yeah? Poietins, so-called, yeah? For example, thrombopoietin. Yeah, which is produced inside the liver, several another. It is endocrine structural units. But liver has an exocrine function, production of the bile. Pancreas also, by the way, function of pancreas is much more complicated. I want to remind you about the Langerhans cells, which is primarily located in the tail of the pancreas. A, B, and C. A produced glucagon, B produced the insulin, produced somatostatin. That's why this is endocrinological function of your pancreas. What is exocrinological? Pancreatic juice. Pancreatic juice, which is contain the main ferments which is necessary for our digestive function. Amylasas, lipasas mainly, not so much proteasas, but much more amylasa and lipasa. Along of all your pancreas, this juice is collected inside of the main pancreatic duct. By the way, in the region of the unsynaptic process, there are an accessory pancreatic duct. Usually they connected with the main one. And if the main one descended to down, come to the level of papilla duodenum major, connected here with the main bile duct and forms ampulla pancreatica, hepatopancreatica, and opening the tip. This accessory one open usually 2 centimeters above in the papilla duodenum minor, and it is open here alone. By the way, this duct in 20% of the cases can be completely absent, and in that case pancreas has only one main duct without this accessory one. They say this is about physiology of the pancreas. Histology, you remember, it has the acinar structures. Yeah, huge amount of the vessels which is surrounding the acinus, primarily in the region of the tail, to make endocrinological function. And the ductular system, which is collecting the exocrine juice, which is produced mainly now from body and head of the pancreas. If tail of the pancreas has mainly endocrinological function, body and tail has exocrinological function. For the adult, weight of it approximately 50 grams. The whole complete length of it approximately 17 up to 20 centimeters. By the way, your pancreas directed from right to the left and from the down to the upwards. Head of your pancreas by skeletal tapete, located in the level of the L2. Body of your pancreas in the level of L1. Tail of your pancreas reach the level of T11, T12. L2, L1, T11, T12. Projectional anatomy of your pancreas. If you will make imaginary horizontal line approximately from midpoint of distance between your xiphoid process and umbilicus, and if you will turn this line approximately in 10 degrees from right to the left side, it will show for you immediately the projectional anatomy of the pancreas into anterior abdominal wall. And mainly, this mentioned line, mainly, if we speak about head of the pancreas, will be in mesogastral compartment. If we speak about tail and about the body of pancreas, it will be in the level of the bicostal line. Means the border, yeah, between the epigastral and the mesopagastral compartment. In anterior abdominal wall, guys, by the way, it will be 3 regions. Number 1, proper epigastrium. Number 2, umbilical compartment. Number 3, left hypochondrial regions. Proper epigastrium mainly for the body, left hypochondrial for the tail, umbilical region for the head, lower portions, level of L2. Idea is understandable for you. I completely describe for you the holotopy, projectional, and skeletotopy of the pancreas. Relation by the peritoneum. Place of its location. You know, then we speak about place of location. We mentioned that the pancreas located in retroperitoneal space, except what? Obviously, except what? Except the tail of the pancreas. You know, tail of the pancreas directed inside of the 2 ligaments, which is connected retroperitoneal space with the peritoneal cavity. First one, it is the renasplenic ligament. Second one, it is the pancreatosplenic ligament. That is the ligaments which is provided the vessels and nerves from retroperitoneal space to peritoneum. Which vessels and nerves? Of course, splenic. And tail of the pancreas will be inside of these ligaments also. That's a tail of pancreas. It is intraperitoneal structure. It is covered from all sides. Head and body, it is extraperitoneal structures. They covered by the peritoneum only from in front. That's a, don't be confused, please. If in your controls and exams you will have a question, where is located pancreas, you will say, of course, in retroperitoneal space. But if will be question immediately about the tail of the pancreas, you will say about this exception. Tail of the pancreas located inside of the peritoneal cavity in the mentioned 2 ligaments. Renasplenic ligament first of all, then pancreatosplenic ligament, which is finally provided this tail of pancreas with splenic vessels into the hilum of the spleen. Distance between hilum of spleen and tip of the tail of the pancreas will be 1 centimeter. That's why we say usually for the students to be very attentive during the surgery, which is called splenectomy. Because then you will make splenectomy, you should apply arterial forceps into the hilum of spleen to ligate it, splenic artery and vein. And immediately in this level, we will have tail of the pancreas, and you can simply clip it by arterial forceps and to provoke formation of the diabetic. Is it understandable? Now write, please, the syncope of the pancreas. Syncope of the pancreas. And minute attention to me. Before to speak about syncope, a little bit about anatomy. I tell you 100 times today that pancreas has 3 parts. It is the head of the pancreas, it is the body of pancreas, and tail. But what is important, guys? Body of your pancreas has triangular or pyramidal shape form. Head and tail of the pancreas, it is the flat structures. That's once again, body of the pancreas has triangular shape, means it has three surfaces. Head and tail of pancreas is flat structures, means they have two surfaces. I want to remind you that for the body of the pancreas, except three surfaces, we describe three margins. This is anterior margin, which is looped to down and in front. It is superior margin, and it is the last margin, which we call inferior. Why inferior, guys? Because if by this exercise book, I will modulate it, the body of the pancreas, it will be turned a little bit ventripedally to you. That's why this margin we call not the posterior one, but we call it inferior one, because it's located below the anterior one. But surfaces of it, it is the anterior surface, posterior surface, and inferior. That's why once again, margins, anterior, superior, inferior, surfaces, anterior, posterior, and inferior. Again, this is true only for the body. Head and tail of the pancreas, it is flat structural units. Now write, please, syncope of the pancreas. Anteriorly to the head of the pancreas, we have a root of transverse colon and mesocolon. Transverse mesocolon, so the root of the transverse mesocolon, which is divided head of the pancreas, into upper 2/3 and lower 1/3. Again, I want to remind you that is the level of papilla duodeni major. Yeah, approximately. Now write, please, in front of the upper 2/3, will be bursa aumentalis, consequently with the posterior surface of the stomach, yeah, which will be face to it. In front of inferior 1/3, we will have the loops of the small intestine because it will be related with inferior compartment of the peritoneal cavity. Write it and please look in the picture. That's approximately in this level. Imagine that we have root of the transverse colon mesentery. Above the root of the transverse colon mesentery, you have superior compartment of the peritoneal cavity. Consequently, in front of your pancreas will be bursa aumentalis, posterior surface of the stomach. Yeah. Below this line, below the root of the mesentery, we will have inferior compartment of the peritoneal cavity. I want to remind you, don't sleep now, especially transfer friends. Listen me. Your peritoneal cavity is split into two compartments with transverse colon and its mesocolon. Let's say above transverse colon, we will have in this level bursa aumentalis. I want to remind you that inferior wall of the bursa aumentalis, it is transverse colon and mesocolon. Let's say what is happened here. Now look to my hand. My hand, it is head of the pancreas. My right hand, which I put horizontally, it is the transverse colon and mesocolon. And you can see that head is divided into two unequal parts. My 3 fingers located above it, my 2 fingers located below it. Part which is above this transverse colon mesocolon anteriorly will face with the bursa aumentalis and posterior surface of the stomach. Part which is below this horizontal line anteriorly will face with the small intestine. I think it's not hard. Continue, please. After crossing to the head of pancreas, root of the mesentery of transverse colon, pass by the anterior margin of the pancreas. Pass by anterior margin of the body of pancreas. look in the picture, please. What does it mean? Let's say, we say that in this level, we have this root of the mesentery. You can see that my hand after pass by anterior margin, this margin we call anterior, as I say here. This is margin which is looked to anteriorly, inferiorly. Let's say this pass approximately along this anterior margin of the. What does it mean? It means that in front of the body of your pancreas, we will have completely bursa aumentalis. Let's say body of the pancreas will be above this line because transverse mesocolon will be in the level of inferior margin. Idea is understandable for you. Let's say in front of the body, right please, that's why in front of the body of pancreas, we will have the omental bursa. I want to remind you guys that between neck and body of the pancreas, we have the protrusion of the pancreas to in front, which we call tuber omentale. Especially we name it by the bursa aumentalis. Why? Because it is the main protrused part of the pancreas to the bursa aumentalis. Of course, pancreas will be covered by the parietal peritoneum, yeah? It will be behind of parietal peritoneum. But anyhow, you understand, yeah, that it will be face to the bursa aumentalis. Body of your pancreas will be face to the bursa aumentalis from anteriorly. Now continue. Tail of your pancreas, medially and in front, face to the spleen. Medially and in front, face to the spleen. Right and look in the picture, please. This is the tail of the pancreas. It comes to the horseshoe-shaped spleen. And you can see that medially it is faced to the high lobe of the spleen, anteriorly to the inferior lobe of the spleen. That is greatly visible in the picture. Not the bursa aumentalis. Again, I tell you, tail of the pancreas is intraperitoneal structure. And it is located inside of two ligaments. It is splenico-renal and pancreatosplenic ligaments. It doesn't have any relation with the bursa aumentalis. It is related with the spleen, medially with the hilum, anteriorly with the inferior pole. Is it understandable for you? Continue, please. Right to the head of the pancreas, we have the duodenum. In the brackets you can write, please, in horseshoe-shaped form. It is surrounding the head of the pancreas, from up, from right, and from down. I think it is not hard, guys. Look, please here. Let's say right to the head of the pancreas, you have the duodenum, which in horseshoe-shaped form cover the head not only from right side, but also from upwards, from right side, and from down. Let's say it forms the horseshoe-shaped form. Is it understandable for you guys? Do you have any problem? Continue, please. Behind of your pancreas, from right to left side. From right to left side. Number one, inferior caval vein. Inferior caval vein. Number two, right renal vein. In the brackets right, please, level of L2. Number three, portal vein. Number four, choledoch, third part, which we call pars pancreatica. Choledoch, pars pancreatica. Number five, superior mesenteric vessels. 1 minute, look here, please. They originated from level of L1, and after they pass between body of the pancreas and the inferior horizontal part of the duodenum. and consequently they give the branches to the large and small intestine, as you remember. Yeah. Continue, please. Next, number 6. I don't remember, or 7. It is aorta abdominalis. Aorta abdominalis. Number 7. Inferior mesenteric vessels. Number 8, left kidney and left suprarenal gland. Left kidney and left suprarenal gland. And now look everybody into the picture. That's why we describe the posterior structures from the level of the head, otherwise from right side to the left side. What will be immediately behind of the right margin, inferior cavalry? As you remember, it's located behind of the ascending, descending part of the duodenum. Next, what I will have here, immediately a little bit to the left side of it. As you can see here, we will have the vena porta. Yeah? Vena porta forms immediately behind of the head of the pancreas. As you remember, it forms by junction of 3 ribs. I will have the third portion of the choledoch. As you remember, first portion we call the supraduodenum, second portion we call retroduodenum, third one we call the pancreatic portion. Then I will have superior mesenteric vessels. Then I will have inferior mesenteric vessels. Then I will have aorta abdominalis from the left to midline. Then consequently I come to the left side, and behind of the pancreas I see the spleen, as I see the kidney, and I see the suprarenal gland. Very, very valuable and important syncope, because otherwise you cannot make any surgical performance. 1 minute read, that's why I give you need to study completely all these topics, and in our